Welcome everybody. Hi, it's Sarah Gardner. I'm a trustee for the Society of Tissue Viability. Welcome so much to our evening webinar. The webinar, Unlocking the Potential Wound Care Strategies for Successful Digital Transformation. I'm really looking forward to this myself, because I know across the UK, even though the National Wound Care Strategy has done a lot of work on digital transformation, we know that in many areas people are struggling to get engagement or buy-in for this. So hopefully we have two incredible speakers tonight, and hopefully they'll be giving you some solutions as to how maybe to get this digital transformation off the ground. Just to say that this is being recorded and it will be available on YouTube via our website within a few days, and those attending will receive a certificate as well within a couple of days of this evening. Or just to say really that even though we've got two presentations, we do like these events to be fairly interactive. So please do use the chat function, and there is the opportunity also to ask questions through the Q&A. You can put them in either of those platforms. We're going to take questions right at the end after the two speakers, and we'll have plenty of time for that. So please do engage in that. I'm sure there are lots of questions out there. So first of all, we're going to start just with a polling question, really just to set the scene. So could I have the polling question, please? Okay, so where are people in their organisations on the digital transformation journey? So you're not on the agenda yet, you're starting to think about it, you're building a business case, you're piloting or having a soft launch solution, or you're fully deployed with a digital solution. Oh, interesting. There's a real split, isn't there? So 40% not yet on the agenda, and I don't think that's surprising, really. Great that people are starting to think about it, but 20% of you are piloting this with 10% fully deployed. So a relatively low percentage that are fully deployed in this, but hopefully after today's presentations, it could be, you know, something that's going to trigger to move that on. These aren't polling questions. That can be closed now. So these aren't polling questions, but I just want to put a couple of points to you, and maybe you could add some comments in the chat. But we're interested in knowing what the sort of barriers are that you're facing in your own organisation. And also, does anyone have any valuable learning that they have through either implementing sort of digital transformation within their organizations? So that could either be successful or unsuccessful. I know it's not always successful, and we'd just like to hear your comments on that. So again, huge thanks to Healthy IO for sponsoring this event. We're really grateful for their support. And therefore, I'm now going to move on to our first speaker, who is Zoe Larmour, who's a service manager in community and ICC care in the North Cumbria Integrated Care. So over to you, please, Zoe. Thank you.
Thanks, Sarah. Good evening, everyone. So thank you for having me. I'm here because in Cumbria we've got a digital wound care strategy that we've been rolling out, and I just want to share our experience and the rationale for where we've come from and where we hope to aspire to be. So if I can have the next slide, please. So just setting the scene as to why, as an operational manager and as previously as a podiatrist, you know, a lot of you will already know the statistics around the cost that we spend on wound care in the NHS, and it now actually costing more than smoking and obesity related diseases combined. And the number of patients, 3.8 million patients that we're currently managing at any given time. And I think the COVID pandemic as well, we're now starting to see some research that is evident that unfortunately the impact on care, particularly with leg ulcer services, with the work that Julian Guest did, is showing that, you know, we did have a decrease of nearly 42% in the healing rate, and a massive increase of over 85% in the time to heal. And that was simply due to the fact that we weren't seeing patients the same face to face. They weren't being seen by specialist teams. 20% weren't in compression. Basically, from a prescribing perspective, from wound care, we saw a massive dip. So there's some real key statistics there that suggested to me as an operational manager that we needed to think about, you know, how we were going to manage wound care. So if I can have the next slide, please. So, and if we can have the next, thanks. The entire healthcare system, it does impact massively. So it has a massive impact. Studies have shown on GPs with 171% more visits. Secondary care, 27% to up to 50% of hospital beds can be occupied at any time. We know that 80% of wound care is sitting in the community at any given time. And care homes, for example, you know, 8% of the care home population at any given time tend to have a wound, of which 50% of that can be pressure ulcer related. So it has a massive impact in the overall system. Can I have the next slide, please? So with thinking about not just the cost that impacted on, and some of the other factors that we wanted to take into consideration was around the fact that we had a lack of information in Cumbria, a lack of data. Our documentation was not as strong as we would like it to be, and that at times wound care, there was a real lack of clear diagnosis. We know that due to a lot of unwarranted variation, there's a lot of differences in advice and guidance, and variations within sort of clinical practice. And it was that lack of continuity and lack of oversight that really, for me, was one of the key drivers to us really starting to think about a digital solution to allow us to sort of track and monitor the interventions, improve patient care and patient outcomes. So if I can have the next slide, please. So in Cumbria, we took a number of other considerations when we were trying to build the business case and engage with stakeholders to get buy-in around this. And if you are considering moving towards some sort of digital solution, then I would really encourage you to start to think about some of these other aspects and gather information to help support your cause. Because I think you have to have a clear idea around what data it is that you require and what KPIs you want to see from the system. We did a lot of work with staff around their competencies and confidence around wound care to gather information, because we also invested a lot of time and some money in actually delivering training packages and enhancing the wound care educational element alongside introducing the digital strategy. We also surveyed the staff around the implementation, because we started with a smaller pilot site to test that the app would work for what we needed it to do. And we will see later on the results of that staff satisfaction survey. We wanted, we knew what our patient incidents and themes were. And, you know, we are continuing to gather some patient case stories that we used as strong evidence from our original pilot site. We looked at what other organisations were doing and what other systems they were using. And obviously we were working already looking at NICE and national strategies and the National Wound Care Strategy guidelines in particular. And it was perhaps the biggest bane of my life, but I did find myself knee deep in spreadsheets looking at NHS supply chain, FP10 spends, specifically around trying to map out what we were currently spending and predicting what we could perhaps save in the future. And one of the biggest things that I also spent a lot of time doing was engaging with different stakeholders and thinking about who it was that I needed to try and influence and get backing from. So in particular in North Cumbria, I needed to get the financial executive on board. I needed to get the performance exec on board, both of which were non-clinical, and was a very good sales pitch for the more clinical based execs. I talked to MP to get backing from the MP and other sort of stakeholders around sort of the system, and that's something that we continue to do now as we kind of move through and have you know, rolled out the app more. If I could have the next slide, please. So basically in North Cumbria, what we wanted to see was this improvement of the patient journey and improved communication as well between teams. And the patient case study here really did allow the with the use of the app to have some proper continuity in care. So that's just an example of what the system looks like and what you can kind of see and the clinicians are working with on a day-to-day basis through the clinical portal. If I can move to the next slide. So in North Cumbria, we knew that we were spending based on the economic predictions of Julian Guest, that 41.7 million was being spent, and a breakdown of the different you know, types of wounds that we had and the actual financial impact. And that to this day has been a blessing in really actually helping hammer home how impactful wound care is on the patient population that we have, and the burden on the workforce. We did have and still do have some recruitment challenges, shortages of band 5 that I'm sure plenty of other trusts experience at, you know, the same as we have, and that lack of central accessibility to wound imagery and data was a real problem. So that set the scene for where we needed to be. If I could have the next slide, please. So digitally, having used the app, what has that unlocked for us? We have much greater workforce oversight. We can identify if teams are maybe perhaps not healing particular types of wounds at a certain rate compared to another team, that then allows us to get in to help support and upskill. We can see if wounds are stagnating or deteriorating. We now do easy and quick caseload reviews based on that information, and teams have huddles or multidisciplinary meetings to try and sort of ensure that the care plan is as robust as it can be to get the patient back on track. It has released time to care. We are utilising a better skill mix across our teams, where registered staff can keep an eye on the patients virtually, and non-registered staff have been upskilled and can provide support for follow-up appointments. We have reduced, or we're looking to try and map out how much we've reduced travel time, but a perfect example is previous to having this digital system, we perhaps would have had to have been out to a patient, and if it was a non-registered member of staff redressing they would have had to take a picture on a digital camera and then drive back to base to show the nurse for them to say, oh, we're going to need that swabbed and we're going to need to put this dressing on. So they would have to go back out to the patient. We now don't have that. They can contact the registered staff at base and ask them to just look at the clinical portal for the latest and give advice and guidance either over the phone or through some sort of virtual platform. We've got better integration and better advice and guidance flowing between our specialist teams, and it really has reduced the admin burden. Can I have the next slide, please? So this is just a slide of, so we did introduce it to a small cohort of staff to test it out. And when we started way back in December 21, the system wasn't interoperable with EMIS. When it did go interoperable with EMIS, that was an absolute game changer for us, because suddenly we were able to share information wider. It was reducing duplication, and it was really saving time, and patient information was being captured at the time of the consultation. And I think that slide just shows that we've gone on strength and strength and strength as we've sort of rolled it out further. Can I have the next slide, please? So I think just for a little bit of flavour, we currently have 168 active clinicians. We have got 235 licenses, and we still are kind of just getting some of the staff fully embedded. We've had about 1,644 patients assessed, but over 10,000 assessments have been completed, of which 98 of those have been infected wounds, and 3,264 wounds being completely documented. So that just gives you a flavour of kind of the numbers that we're seeing in North Cumbria since implementing it. Can I have the next slide, please? So for me, it was really, really important that we start to capture the caseload visibility. So the pie graph there is an example of what we see on the dashboard. So we know that at this point in time, this team had 27% healing rate, that they had maybe 17% that were deteriorating, and 1% static. So the visibility that we have now is being greater. It has, as I said, created that better clinical oversight, and it has shown in some cases where we've seen admission avoidance or improved patient engagement, because they're actively seeing the changes in their wound, be it good, be it bad. And we are hoping that we can evidence that it will have an impact in the future on improved discharges and length of stays. This is the survey that we did with the 66. We had 66 active users as part of our original implementation, of which we got a 45 user response rate, so quite a high response rate. And the 77% said it was a very easy app to use. 84 said they were really confident with the use of the app. 71% said important data to EMIS was exceptionally easy, and 62% used the app to review dressings and to engage patients in their treatment. So that was just a bit of a flavour of how the staff felt as they were initially rolling out the initial pilot teams. Can I have the next slide, please? And then we've had some absolutely amazing comments, and we probably could fill this screen several times over now, but one of our very proactive HCAs, is very supportive of this, and just simply would have wanted this app years ago, basically, because it's so easy to use. Another nurse saying that with the use of their iPhones, The documentation is simpler, particularly in the patient's home environment. And it's also quick and easy to show colleagues to get advice and guidance and for handovers, etc. And we did have a local counsellor who did express his thanks for his treatment and being able to see that progression of improvement with his wound, but also the continuity that he got whilst not actually seeing the same podiatrist week in, week out. The actual fact that the app did give him some continuity and some confidence in what was happening around his care. So there's some lovely comments there. Can I have the next slide, please? So where are we at now? We're in the process of rolling out, as I said, the 235 users, and the main aim is to keep people very much at home wherever possible. We have integrated it across the community. So we now have district nurses, podiatrists, tissue viability nurses. We have the acute vascular team who have access to visualising the system and being able to offer that advice and guidance in a quick and timely way. And we are hoping that in the future we will be able to, roll it out in an acute ward and pilot it and try and look at whether we can improve discharge, whether we can reduce length of stays, and also look to get it into the emergency department. So if people are coming into that setting where currently they don't have access and visibility to our EMIS system, they will be able to make clinically safe decisions because they will be able to see the case and the assessments and the care plans for the patients. And we have also just completed a 4-day CPD event across the county, covering topics like continence, tissue viability, the rollout of healthy IO training, and vascular. So we've used that to enhance and upskill the staff that we've got. If I can have the last slide, or second last slide. So for me, the digital wound care management system or tool has very much started a bigger conversation across the system. We have got engagement from our secondary care colleagues. We do have conversations being sparked with our primary care colleagues now who are interested in how this can work and how we can engage and how we can share patients better in the future. Can I have the next slide? And I think just as a summary, basically, for the wider ICS system, there is greater, benefits, not just on the fact that we can track what is going on with wound healing, but improving care, reducing costs, having a more green agenda because we're reducing travel, having better visibility and reducing system costs by maybe being able to adhere better to wound care formularies, and increasing the capacity and the resource of sometimes very specialist teams that are exceptionally small. Thank you very much.
Thanks, Zoe. That was really interesting, and it's really exciting to see how you went about that sort of process and the successes that you've had. I think it will be very inspiring for those that maybe are struggling on the call today with trying to embed this. So you've given some fantastic solutions there of how you went about it. We'll take some questions at the end. There's been quite a few comments in the chat, but if you have any questions for Zoe, please do add those to the Q&A or the chat. Also, if you have any specific questions for our Healthy IO colleagues, I think there's already a bit of conversation going on, but they're available also to answer any questions. So let's do that. Okay, so we're going to move on to our second speaker now, and I'd love to introduce Louise Parker, who's a quality improvement and project lead from York and Scarborough Community Services. So over to you, Louise. Thanks very much.
That's great. Thank you, Sarah. I'll wait for the first slide to come up. So hopefully when I go through my presentation, it will be a compliment there to Zoe's, and certainly a lot of the success that you've heard from Zoe's presentation is something that we would absolutely resonate for us here in community services across the York and Scarborough area. So could I have the next slide, please? So I'll start a little bit, if I may, with where we were. We a couple of years ago now, and we had in our community services a long-standing ambition from our TVN team to use some sort of clinical imagery to support our wound care approach. And that really came from a couple of places. We're a community service. We cover a large geographical area, which covers North Yorkshire, Central York, and then down to our boundaries in Selby and Doncaster. We have a really small tissue viability team who consist of 5 people who cover community and also 3 large acute hospitals as well as 6 community units, and we have 5 community nurse teams, all of whom work in a locality area and who manage a caseload within that area. And as you can see there, wound care was really high, consists of about 50% of the caseload for our community nursing team. And what we knew as part of our community nursing team, when we're not attached to GP practices anymore, we have big teams of around 30 to 40 people, and they cover the care for patients in a geographical area with a number of GP practices as part of that locality. And what we've seen through that is that there is therefore a real devolved responsibility for wound care, care and treatment across pretty much everybody within that community nursing team. And that's great in terms of resilience to be able to provide capacity to be able to meet the demand of wound care services. But what our caseload holders really felt is that we were starting to see some loss of continuity of care. So we'd tried on a number of occasions to think, actually, does a photo, a clinical image of a wound actually start to improve that continuity of care and visibility of progression of hopefully healing rate for our district nurse caseload holders? And does that also start to help our TVN teams with any of those clinical reviews? Because the TVN team in particular were travelling quite significant distances to be able to do joint and face-to-face visits within patients' homes. So that's why we'd been looking at using photography or clinical imagery for quite a while, but actually we'd not found anything that could really meet our needs and that would be used on a consistent basis. And as you can see there, one of the other real downsides for us about just taking a photo on a phone was that actually the quality of that imagery was really variable. We have quite a lot of our community nurses who do drop their mobile phones, and they do have smashed screens, and they're not replaced. And so some of that imagery was grainy, but also the quality of the imagery could be incredibly variable, just depending on the type of situation that our clinical colleagues were having to take that photograph in. Next slide, please. So we were in a little bit of a pickle. So we decided, right, we really need to do something about this. And what we set out was within our organisation. So this wasn't, I guess, as Zoe has described, a large scale change piece of work across a footprint of an ICS. But we wanted to look within our own organisations and within our community teams, actually what would be our recipe for success if we wanted to really make a go of what we thought was a very important thing, to use high quality clinical imagery in the support of delivering better and more consistent wound care. And these are the things that you can see here on the screen. So we did start with actually what was our needs, well, what was our case for change, and that's what I've just been describing there. we didn't want to start until we had the backing of our senior clinical and operational staff, because we knew that their support, even though they weren't going to be the people who would be on the front line using the app and taking those images, we absolutely needed their support if we came across any barriers, but also we needed their voice to be able to share some of the successes. And again, I heard Zoe talking there about even lobbying an MP, which I did write down. So I thought that was great. We wanted a product which would deliver against our use case, and that was really important for us. And then we also wanted to have a clinical lead. So what we absolutely recognised is that to be able to move from the place where we started to using clinical imagery in a consistent space, it had to be clinically led. It couldn't be top-down imposed by an operational team. So our clinical lead, who isn't with me today, but who is Keely Chapman, some of you may know Keely, I know Keely's spoken at a number of events, was absolutely key as part of this project, and I'll go on and explain why. And then the bottom four are the other things that we did in order to get us ready to work with a test team. So we were quite carefully mapping out what we wanted our solution to do. We did ask for a volunteer team to test the product. So it was done on a voluntary basis. I was involved from a project and improvement approach just to make sure that we kept ourselves on track, and we did use some quality improvement methodology, which was really helpful to refer back to when maybe things didn't go quite as planned, which is always the case with any change project, whether it's digital or non-digital. You start with your best plan, but you have to be able to alter and adapt as you move along. And then we wanted a vision to really start to think about actually how do we have a sustainable implementation plan. So we began with the end in mind. And what that looked like for us is, although we knew Keely needed to be our clinical lead, we needed to do the training, how did we actually exit a team and leave them able to self-sustain that clinical imagery for them in the team and continue to train new people as they came along, because we knew we couldn't wrap it round one single person all the time, because otherwise Keely would become our bottleneck to be able to roll out this digital change to other teams. So that's how we started. Next slide, please. This is just a little bit around, as I've already described, our route to finding the product and where we were in terms of our case for change. We really started with a vision, particularly for our TVNs, that we actually wanted to try to move to some virtual caseload reviews or virtual reviews of patients who required escalation to an expert, because we knew that we had delays due to our pretty small resource in our TVN team of having those joint visits with our DNs. And we wanted to, one of the really key things from our TVN colleagues was to try to be able to be more responsive to that call for help from either our district nurses or our community nurse teams. And for our district nurses, as you can see there, one of the things that really resonated when we asked them what they wanted in a digital solution is they said that they wanted something that enabled them to see their wound caseload, a digital product, but where they had confidence in that product, that the image was of sufficient quality to allow that virtual review, and that they were confident enough to say, actually, on the back of this virtual review, I can prescribe a change in treatments for this patient without needing to do that. Oh, I'm not quite sure, maybe I better do a face-to-face visit just to make sure. So those were a couple of things that came across really loud and clear for us. And then what we started to look at is, okay, so what can we find in a digital product? We did want it available on a mobile phone because our community nurses didn't want to take any other pieces of equipment into patients' homes. They're laden down enough with what they have to carry. We wanted it to be interoperable, and that's been a real breakthrough. Again, as Zoe said, it will be a game changer for us. System 1 has been slower to come on stream than EMIS, but we're really excited that it's there now. It needed to be easy to use, and we wanted to get that improved consistency of that wound image presentation. So those were all the things that we were looking for. Next slide, please. And then really just to complement Zoe's presentation, this is the type of approach or some of the methodologies that we actually started to really think about as we were, once we'd chosen which product we wanted to try, about what we underpinned our change process with. And the top couple, Rogers curve of adoption, which I'll go on and show the East behavioural change theory, and really working with that model for improvement, testing, PDSA cycles and peer-to-peer support, I would say were absolutely key in enabling us to start, helping us to keep on track, not becoming despondent when it didn't go quite right and quite to plan, and I'll show you that in a tick, and really being able to, I think, give some justification to where we were. And actually, Keely, if she was here, she would liken this approach to actually how she approaches wound care anyway. So starts with the initial assessment, starts with the best treatment theory. Sometimes things don't always go to plan, but actually has a methodology in a back pocket where she can maybe choose and pick some other products or other treatment plans as you move forwards with that patient's care. Next slide, please. So as you can see, although we focused on, we knew that we needed to get the process right, I would say our reflection is that 80% of our time was spent with people and was spent with the people change. And this is the Rogers curve of adoption, which we really used in order to underpin our approach. So we wanted to find the innovators in the team that we were working with. Who were the people who were willing to give this particular product a go, were quite happy if things didn't go right to start off with, wouldn't be despondent, and actually would keep trying to get it to work because they were just really creative and were really, I think, quite innovative in wanting to try something different. We also wanted to find the early adopters or the followers. So not only those people that actually would give something a go, because what we know and what you'll see at the end with the video is that sometimes being a lone wolf doesn't always create the follower of somebody else who will actually adopt and do what you're doing. So we wanted to find those early adopters, and then we went to the late majority, and we had a real ambition, as you can see there on that bell curve, that at least 50% of every team would start to use an app, and in our instance it is Healthy.io, but I think this is applicable to any change process that you're doing, and particularly digital, that would start to use this new technical innovation as business as usual within their service. And we also knew and absolutely recognised that we would have people, even in a volunteer clinical team, who didn't want to do it and possibly wouldn't use the app as well. So those people there who are the later majority, the people who watch and wait, see what happens with the colleagues, and then probably will jump on board because everybody else is doing it. So actually it looks okay and there's something in it for me. But we know, and it has worked out this way, that there is around that 10 to 16% of people, so it is a few within our teams, who just do not scan. And there's a variety of reasons for that. Next slide, please. The other one that we really used to underpin our approach was the East framework for behavioural change. So it needed to be easy. It needed to be attractive, so we wanted to be able to share the impact of using this particular digital product. We were really conscious that we as humans are really heavily influenced around by what people say and do, and so we were really conscious of being able to share what worked and also what didn't work, and because that was really important as part of our learning, and we wanted to make it quite timely as well. So what we mean by that is that it was part of a priority, it was part of a piece of work that we were doing around wound care, that our clinical teams could see, hopefully part of that whole strategy to supporting them to support care for patients who had wounds. Next slide, please. And then the third one that we really heavily drew on quality improvement methodology is this model for improvement. So we absolutely said to our test team and also our tissue viability team, who started as a very early adopter of this particular act, is that actually just give it a go. Just try something out. We have already done what we're trying to accomplish. We had some measures and we'd already done our use case. Here's the app, here are the funds. Go and give it a go and do some of those PDSAs. Test with one patient. You don't have to get all your caseload on to start off with. Just give it a go with a couple of people. And that's how we started to build momentum and started to build confidence and started to build some of that learning. So we didn't want to go straight into everybody in the team has to be completely fully trained and absolutely everybody has to do this for every patient every time. We wanted to work on a PDSA model for improvement cycle. And I think that really helped, particularly for that initial team, to just start to get them going. Next slide, please. And then this was the final one that Keely, I think, was really instrumental in saying to the teams, which was, please don't come back to me and ask for permission to do something. I trust you as clinicians and you've been trained. So as long as you're following your professional conduct, just give the app a go. If you think that a wound needs a scan and needs a photograph and you want to do something with it, absolutely give that a go. And what came out from that was some real richness, I think, of things that we hadn't even considered might actually be beneficial by using a digital solution. We very much started off with what would work well for the TVNs and what would work well for our community teams. But actually what started to emerge were stories around patient compliance, particularly into some of the leg compression, where our patients could actually see, because it had been recorded in a really good quality image, that their wound was starting to heal, and that improved compliance. And we'd never ever thought that that might be something that we would do. And it was only because one of our nurses said, oh, I'm going to show this to my patients, you know, because they were really struggling before we used this clinical imagery to gain that compliance, particularly from leg compression. We've had some great feedback from GPs as well about how easy it's been to share the image and support some further care and treatment for our patients. And we have had one story which feels sad in a way, where one of our tissue viability nurses took an image of a wound and actually sent it across to our dermatology oncology team, and that patient was given a really urgent appointment where they'd actually been struggling to ask the GP to send an appointment through for that patient. So there have been, you know, lots of advantages there, but that's why we've put this slide up as part of our presentation, because it really was about that opportunity for our really highly competent and qualified clinicians to give something a go without needing to ask for that permission. Next slide, please. And this is the last one, so I hope this will play. I'll sit back and let you watch it. This is what we have used to keep ourselves on track around our leaders and our followers. So
if you've learned a lot about leadership and making a movement, then let's watch a movement happen start to finish in under 3 minutes and dissect some lessons. First, of course, a leader needs the guts to stand alone and look ridiculous. But what he's doing is so simple, it's almost instructional. This is key. You must be easy to follow. Now here comes the first follower with a crucial role. He publicly shows everyone else how to follow. Notice how the leader embraces him as an equal. So it's not about the leader anymore. It's about them, plural. Notice how he's calling to his friends to join in. So it takes guts to be a first follower. You stand out and you brave ridicule yourself. Being a first follower is an underappreciated form of leadership. The first follower transforms a lone nut into a leader. If the leader is the flint, the first follower is the spark that really makes the fire. Now here's the second follower. This is a turning point. It's proof the first has done well. Now it's not a lone nut and it's not two nuts. 3 is a crowd and a crowd is news. A movement must be public. Make sure outsiders see more than just the leader. Everyone needs to see the followers, because new followers emulate followers, not the leader. Now here come 2 more people, then 3 more immediately. Now we've got momentum. This is the tipping point, and now we have a movement. As more people jump in, it's no longer risky. If they were on the fence before, there's no reason not to join in now. They won't stand out, they won't be ridiculed, and they will be part of the in crowd if they hurry. And over the next minute you'll see the rest who prefer to stay part of the crowd, because eventually they'd be ridiculed for not joining. And ladies and gentlemen, that is how a movement is made. So let's recap what we've learned. If you are a version of the shirtless dancing guy, all alone, remember the importance of nurturing your first few followers as equals, making everything clearly about the movement, not you. Be public, be easy to follow. But the biggest lesson here, did you catch it? Leadership is over-glorified. Yes, it started with the shirtless guy, and he'll get all the credit, but you saw what really happened. It was the first follower that transformed a lone nut into a leader. There's no movement without the first follower. See, we're told that we all need to be leaders, but that would be really ineffective. The best way to make a movement, if you really care, is to courageously follow and show others how to follow. When you find a lone nut doing something great, have the guts to be the first person to stand up and join in.
Thanks, Kerry. I think you can probably stop it there. So hopefully quite appropriate with Glastonbury just finished. But that's what we really felt really helped for us. So Keely was our leader. She absolutely had people who were prepared to give it a go in her community teams, and then others joined in. And I think that's one of our key messages. Thank you. I hope that's been useful.
Oh, thanks so much. That was absolutely brilliant. And I will never forget that image of that dancing man on the hill, but it's absolutely true, isn't it? Thanks for that. There's been lots of comments in the chat, but also some questions as well. So what I'm going to do is just put questions to both of you, if that's okay. Zoe, you started off by really talking about data, and we know there's a huge need to gather data to prove that there's a case that we need to change, isn't it? But I know that you collected data, you know, through your sort of pilots and things, but was there a trigger? I mean, how did you know? You know, you gave us some statistics about maybe, you know, how many people had a wound, but what data systems were you using to demonstrate there was a need to maybe take on this digital technology?
So actually a lot of the evidence was national data because we didn't have it locally. And so it was really hammering home the point that we didn't have it locally. We'd done some audit work, which was really laborious, you know, sequence stuff that really was very time consuming, you know, for the teams to do. And just really hammering home the point that it wasn't at our fingertips, really. So no, we didn't have a lot of the information just to hand to be able to do it. We're now be able to see that and demonstrate what we are actually doing. And as a leader sort of in North Cumbria, I had no assurance and no accurate way of measuring what we were doing or what we were delivering, and that was a bit scary.
But that's quite a powerful point to put forward to those that, you know, need to make or to give you the permission to do it, say from a financial point of view. You know, I've heard from some people anecdotally that they've been asked to, well, give us the data to prove that we need this. But like you said, if you haven't got systems in place or can easily extract that data, how do you do that? Was this the same for yourself, Louise?
Yeah, that definitely resonates with us. It's really hard to get the data out of our current systems to be able to provide the case. We did try to wrap some financial costings around some of the ways that we were currently working. Like I said, you know, long travel times for our district nursing, days delay in response, district nurses that were then going out and doing second visits because they needed to do a review of a patient. So we gathered some data around that and pulled some costings together. But it certainly wasn't, I would suggest, a very robust data analysis. And we did really draw really heavily on the National Wound Care Strategy, its recommendations, its best practice, and that was really super useful for us. And then, to be honest, it was a leap of faith. So you know, that's where we ended up, and we are still with our piece of work now gathering our data around return on investment for that continued investment in this product.
Brilliant, thank you. There's been quite a few comments about the use of, the technology, the smartphones needed to support this app, and the NHS historically having sort of fairly basic issue smartphones, if it's a smartphone at all. The cost of replacing them must have been quite a considerable financial pressure or a commitment. So, and also there's comments about maybe people being worried about using smartphone and app technology, one because maybe they're unfamiliar with it, but also worried about the security side of things. I'd like to put that to both of you as to, if that's what you found and how you went about sort of being able to convert maybe basic equipment into sort of more advanced technology in terms of smartphones.
Louise, do you want to go first? Or?
Yeah, I'm happy to take that. So we were definitely in the place where our community nurses were issued with mobile phones that wouldn't hold this app. So we did a couple of things. We're really fortunate. We work in an acute and community organisation, and at that point our acute organisation were looking to procure some handheld devices to support some work that they wanted to do on our acute wards. So we linked in with them and said, look, if we give you back our mobile phones which are fit for use, can we then jointly procure something which would enable our community teams to have the higher grade mobile phones? That was one route in which worked for us. We did go to charitable funds for some of our mobile phones because that helped us with our test case. So we were able to do that. We were also able to just apply for some money out of our care group because we made the case that the higher grade mobile phones, which we wanted one with 5G on for our community nurses, would give us more reach into our more rural areas, which actually for lone working as a community nurse became really quite important. So there were a number of factors that we tried to use to persuade that additional investment into a higher grade technology mobile phone, and I think for us we've been quite fortunate to get that over the line. But it was about that well-used phrase, thinking out of the box, being a little bit more creative, linking in with other teams, trying to recycle where we could.
Thanks. I know that Zoe, from a North Cumbria point of view, because I'm up in that way myself, there's a huge rural community. So was this the same for yourself when you were looking at the smartphone technology you needed to use?
Yeah, we'd already started a conversation about, the safety element, about other systems that we have implemented like eCommunity, and the need for these devices, and the fact that as community teams, that was really, they needed to be agile. So we've been fighting that good fight for a long time before we looked to implement Healthy, and it carried on. And Healthy IO just added an extra dimension as to why they really should fund it in a sense and help support it. I mean, we actually started with our rollout because our smartphones that we had were not compatible with the app. So we started with some iPads, and I would say if anybody is thinking of doing that, do get the right digital device, because again, the uptake from staff and was much better when we started using the iPhones from the iPads. So do get your digital technology part sorted first of all, because it will just remove a challenge and a headache that you don't need. But at least it got us in the door, and we did get it across the line and get them funded so that we can utilize the app.
Right, great advice. There's a question here about how you selected the app. Did you have to tender? Because we know when there's a big cost in terms of what we, whether we're purchasing things with the NHS or services or whatever, if it's over a certain amount, we sometimes have to tender. So how did you go about that? Louise, do you want to come in first?
Yeah, happy to. So when we started a couple of years ago, we did write out our specification of what we wanted to be able to achieve from clinical imagery. And then what we did is we looked around all the providers at that point in time to see whether or not their particular product would meet the specification that we had written out, so the things that we wanted the app to be able to do. And at that point, Healthy IO for us came out on top, and we were able to go to a direct award because there wasn't any other app that would do what we wanted it to do. And I think that the change on that for us was about the quality of the imagery and the automated measurements that was on the application, which would enable us to do consistency of wound measurement, gather the data, and what we wanted to do to be able to deliver these virtual clinics. So, and I think that's how tendering works anyway, isn't it? If there's only one product on the market that meets your specification, you can go direct to award. But if there are multiple products on the market, you have to tender over 50k.
Yeah, so the same for you, was it, Zoe?
Yeah, so we went with the direct award because it was the only product that was interoperable with EMIS, and that was a key element to reduce duplication of admin and the burden and try and release some time to care. But equally, you know, it was the system that had, as Louise said, the digital imagery that we were aspiring to as well. So it kind of ticked all our boxes and was already sitting in part of the NHS framework. So it was there to be offered as a digital direct award.
Right, thank you. Louise, you mentioned about the importance of having, you know, the support and the backing of senior leaders within organisations. Who do you think the key sort of stakeholders are to get on board? Who's more tricky than others in your experience? Or was it just no problem at all for you?
Yeah, I would say because this is predominantly a product which is used by our nursing colleagues, the head of nursing for community services and our head of community services were absolutely key, because they are the representatives of community services in our more senior forums. So those guys were key, and that was quite easy really, because they lived and breathed the stories that our TVNs and our community nurses said anyway. So it all felt very real to them. The people who were probably trickier were finance, and actually in a way I welcome the challenge from finance. You know, is it really worth it? Is it going to do what you say? How are you going to measure what your changes are? And that they're not questions which are meant to be difficult or push you off track. They're meant to be questions which actually just help you, make you think a little bit more. So I would say finance, because they're more removed. They just don't live and breathe what some of those challenges actually look like. And we did actually invite some colleagues to go out with our community nurses and see what it was like and see what the challenges were like. So that worked really, really well for us. And then it's just fighting through all the other pressures that the executive team have on their radar. And if you're in an acute trust as well, you know, you're fighting for your place around ED, cancer, elective weights. Like, hey, there's wound care over here. You know, so we actually were quite fortunate that there's an emerging wound care strategy, which was really useful as well. So we tagged onto the back of that with the clinical imagery.
Yeah, and I think your huge focus on improving wound care must have really helped actually, Zoe, in when you were trying to sort of take this idea to those that needed to make decisions as well. Were any more tricky than others in your experience to convince?
Yeah, some of the execs that were non-clinical took a little bit more to get their head around the benefits of it, and actually needed to really kind of see what it looked like. So you can't see that in a business case. So like a PowerPoint presentation, you know, with evidence of what the dashboard would look like what the clinical portal would look like, and utilising some of the other trusts, you know, information as well to really sell that home, along with the staff survey results of how easy it was to use and how much they enjoyed it, and the patient stories was really key to getting them sort of hooked. And I think, you know, in North Cumbria we are an integrated acute and community team, you know, and yeah, it's that competing agendas, elective recovery and, you know, ED, as you say, and patient flow. And so we did have to then start to think about, as we were talking to them about, you know, what is their key priorities, and angling the business case to kind of hit those areas and address those areas, whilst also really clearly saying, but in the community, we want to embrace this because that's where 80% of these wounds are. And if we keep them at home, they're not going to go to those front doors of the acute hospital.
That's actually fantastic. Well, I'm really genuinely think that both of your presentations and just sort of the discussion we've just had now will inspire a lot of people to move this forward. I know personally, you know, when I was working in Oxford, we wanted to try and push this forward, you know, years ago, and always came up about barriers. I could have done with these presentations, I think, at that point to sort of help move things forward. So change is difficult, and I think you've given some brilliant examples of sort of some of the strategies you can use to move this forward so we can transfer digital technology within wound care. It's absolutely essential, isn't it? Sorry if I haven't got to your questions. I know there's been lots of comments and questions there, but you can contact Healthy IO directly if you have any specific queries about their technology. And I really want to thank them for sponsoring the event today, but particularly our two speakers, Zoe and Louise. Thank you so much for your time, and I really hope you've all got a lot out of the session.